Black Cohosh gets sold like the herbal shortcut for hot flashes. If someone is waking up drenched 3 times a night, changing pajamas, and trying to avoid hormone therapy, is this a real option, or mostly a menopause aisle legend with a confident label?
It is not a clean yes or no. The best recent synthesis is awkward. One International Menopause Society review found moderate certainty evidence that black cohosh may improve vasomotor or overall menopausal symptoms, while another 2026 herbal review found the 2 black cohosh trials it identified showed no measurable effect. That contradiction is not a detail to hide. It is the lesson. Menopause hot flashes are not just feeling warm. Falling ovarian hormone signaling can narrow the brain's temperature comfort zone, so small shifts trigger flushing, sweating, and wake-ups. Black cohosh products contain multiple plant compounds, and mechanisms are still debated. Clinically, though, the question is simpler. Do daily symptoms improve beyond placebo when people track frequency, severity, sleep disruption, and quality of life?
Why do menopause trials seem especially messy? Is it because hot flashes naturally fluctuate because sleep changes amplify everything? Or because placebo response is big enough to make a weak supplement look dramatic if the study is short or the baseline is unstable?
Exactly. And black cohosh adds a second problem. The bottle is not always the experiment. Trials may use a named extract, a specific dose, or a combination formula. Store products can differ in plant part, extraction method, concentration, and quality checks. So black cohosh worked may not transfer to any random capsule, especially if the label is vague or the product is a proprietary blend.
Some newer trials look impressive, but they combine black cohosh with soy isoflavones, lignans, chasteberry, or evening primrose. Can we credit black cohosh for those improvements? Or is that like tasting soup and declaring one spice responsible for the whole flavor?
We should read them as formula evidence, not black cohosh proof. A 2025 randomized trial of black cohosh plus soy isoflavones and SDG lignans reported about a 48% greater improvement in total menopause rating scale score versus placebo over 90 days. That is a useful signal for that studied package. But the active package had 3 major components, and modest hormone changes do not tell us which ingredient mattered. Before anyone experiments, the clinical gate matters. New bleeding after menopause, bleeding between periods, unexplained pelvic pain, pregnancy, active liver disease, or a history of hormone-sensitive cancer should not be handled by adding an herb. Those are clinician conversations first. Supplements can also interact with medicines or create surgery risks, so the natural label does not remove the need for a medication and diagnosis check.
So, who is the best fit person? Someone with mild hot flashes, severe ones, or someone who wants to avoid hormone therapy but still needs something practical and measurable before deciding whether the supplement deserves a place in the routine?
Best fit is a person with bothersome vasomotor symptoms who cannot or does not want to use hormone therapy, has no red flags, and is comfortable with uncertainty. I'd make it testable. Record hot flash frequency, severity, night sweats, sleep disruption, and mood for 2 baseline weeks, then compare after 8 to 12 weeks on one consistent product. If caffeine, alcohol, room temperature, or sleep schedule changes at the same time, the signal gets harder to read.
What should people look for on the label if the research used specific extracts? Is standardized black cohosh enough information, or should the label tell you the botanical name, the extract amount, and whether other active ingredients are quietly bundled in?
It helps, but it is not magic. I'd want the botanical name, the extract amount per serving, directions that match ordinary adult use, and a clear list of every other active ingredient. Third-party quality seals are useful because dietary supplements are not pre-approved like drugs for effectiveness before marketing. Avoid mystery blends if you're trying to learn what helped, because a vague label turns a personal trial into a guessing game. The liver caution is uncommon but important. Case reports have linked black cohosh products with hepatitis and even severe liver failure, though causality can be hard to prove because products vary and people may take multiple substances. That uncertainty cuts both ways. It does not prove every bottle is dangerous, but it does justify a low threshold to stop. Seek medical care for yellow skin, dark urine, severe fatigue, right upper abdominal pain, or persistent nausea.
If someone improves a little, how do they decide whether that is worth continuing? Are we looking for zero hot flashes or a meaningful drop that makes sleep and daily life easier, like fewer soaked awakenings or less disruption during work?
A meaningful drop is reasonable. Zero is not the standard. But the medication boundary stays active. Tell clinicians about black cohosh, especially if you use liver-affecting drugs, cancer therapies, anticoagulants, sedatives, complex cardiac medicines, or are planning surgery. The NCCIH point applies broadly. Supplements can differ from study products and can interact with medications. Disclosure is not asking permission for every tea. It is preventing blind spots.
So the honest verdict is not black cohosh cures menopause. It is possible help for some hot flash or menopause symptoms, evidence tangled by extracts and combination formulas, and a trial only makes sense if the product is identifiable, symptoms are tracked, expectations are modest, and liver, bleeding, pregnancy, cancer, or medication red flags are respected.